This module in the series of neuropsychiatric syndromes is on sleep for the nurse practitioner. This module will highlight sleep and dementia. My name is Melody Harris. I'm an associate professor at the University of Arkansas for Medical Sciences and a member of GAPNA. Welcome to the education module, Sleep and Dementia. In this module and throughout this series, the term persons living with dementia will be used throughout to emphasize that dementia is a diagnosis and does not define an individual. Dementia is a highly stigmatized disease process. The term persons living with dementia is used to promote positive language and a more person-centered approach. The purpose of this module is to discuss sleep disturbances in older adults living with dementia. Sleep disturbance is a neuropsychiatric syndrome that is common in older adults living with dementia. In one systematic review, the pooled prevalence of sleep disturbance is 39% in Alzheimer's dementia and 24.5% in persons living with mild to moderate dementia. Poor sleep is closely associated with cognition and is a risk factor for dementia. Sleep disturbance results in polypharmacy, morbidity, and mortality, and is a cause of institutionalization. Physiologically, sleep is controlled by hormones that are released from the suprachiasmatic nucleus. The suprachiasmatic nucleus is located in the anterior portion of the hypothalamus and is a pacemaker for the circadian system. The pineal gland is located within the brain. When sunlight reaches the pineal gland, melatonin is released. Stages of normal sleep are N1, N2, N3, and rapid eye movement of sleep, or REM sleep. N1 and N2 are categorized as light sleep. N3 and REM sleep are categorized as slow wave sleep or deep sleep. There are age-related changes with sleep. One myth is that daytime napping and excessive sleep is a characteristic of aging. Another myth is that older adults need less sleep than younger adults, when in fact, the National Sleep Foundation recommends that all adults require about 7 to 8 hours of sleep each night. In the 5th decade of life, there are changes in sleep architecture, including earlier bedtimes and rise times, longer time in bed to fall asleep, less total sleep time, sleep fragmentation, and reduced slow wave sleep. Interestingly, most changes in sleep patterns occur before age 60, and then they stabilize. One prospective cohort study showed that older adults experience lower average sleep efficiency, longer sleep latency, variability in sleep efficacy, and total sleep time that leads to a risk for mild cognitive impairment and dementia. Circadian rhythm and sleep disturbances occur due to sleep disorders, physical, mental health, and pathological changes associated with neurodegeneration. Compared with other populations, persons living with dementia present with atypical symptoms. Irritability, daytime sleepiness, hallucinations, confusion, and decreased cognition are symptoms of sleep disturbance for persons living with dementia. Symptoms of sleep disturbance are consistent with types of dementia syndromes. Obstructive sleep apnea is common with vascular dementia. Reduced slow wave sleep is seen early in the course of Alzheimer's dementia. Restless leg syndrome and periodic limb movement disorder is common in Lewy body dementia and in Parkinson's dementia. Rapid eye movement sleep disorder is seen in Parkinson's disease. A common feature of REM sleep disorder is acting out dreams, which can be interpreted as psychosis and sometimes overlooked as a symptom of a sleep disorder. Slow wave sleep activity is present in mild cognitive impairment and early in the course of Alzheimer's dementia. For persons living with dementia, there are increased nighttime awakenings and decreased non-rapid eye movement and slow wave sleep. Fragmented sleep throughout the daytime and nighttime is a very common feature in dementia. For persons with dementia, the cause of sleep disturbance is multifactorial. A comprehensive sleep assessment that includes overall physical, mental health, and even dental health. Sleep patterns should be screened using tools that are relevant to older adults, such as the Pittsburgh Sleep Quality Index or the Epworth Sleepiness Scale. A sleep diary that is kept by the older adult or caregiver to include daytime and nighttime activity for a 2-week interval is also very useful in evaluating sleep. Comorbid conditions such as cardiac, gastrointestinal, musculoskeletal, and pain require evaluation with a focus on sleep. Sleep disturbances are common with mental health conditions. A sleep assessment considers previous sleep patterns such as nighttime shift work and sleep preferences. In addition, medications such as beta blockers, selective serotonin reuptake inhibitors, diuretics, thyroid hormones, and other medications can influence sleep patterns. Suspicion of sleep disorders require referral to a sleep specialist. In addition to a sleep history, polysomnography and actigraphy may be used in the objective diagnosis of sleep disturbances. Polysomnography may be considered in the diagnosis of sleep apnea, especially for those with a large neck circumference. For older adults with dementia, polysomnography may be restricted due to multiple wires and nighttime duration of the test. In addition, the use of CPAP may not be tolerated in moderate to severe dementia. In some cases, actigraphy may be used in the evaluation of sleep patterns. Actigraphs are small devices that resemble a watch and is usually worn on the wrist that detect motion. There is a computer device within the actigraph that records movement. The data can be downloaded into software and interpreted. The diagnosis of sleep apnea is limited using actigraphy, but it can estimate total sleep time. Sleep apnea and restless leg syndrome are examples of sleep disorders. Unexplained nighttime wandering is a symptom of restless leg syndrome for persons living with dementia who may be unable to express uncomfortable lower extremity sensations. Treating anemia associated with restless leg syndrome may relieve these symptoms. Although excessive daytime sleepiness occurs with sleep apnea in younger adults, older adults with obstructive sleep apnea often present with insomnia. Insomnia is often due to comorbid conditions. Congestive heart failure is one example of a comorbid condition that contributes to insomnia. Avoiding late-night meals and sitting up after meals are interventions for gastrointestinal reflux. Osteoarthritis is the most common chronic condition in older adults. Pain management can improve sleep. Decreased eyesight is also a common sensory deficit that contributes to poor sleep. Nighttime awakenings with difficulty staying asleep is common with depression. Mania with long intervals without sleep is common with bipolar disorder. In summary, sleep disturbance is a neuropsychiatric symptom that is common with the diagnosis of dementia. Neurodegeneration contributes to poor sleep. Poor sleep is a risk factor for cognitive impairment. Sleep affects physiological and mental health. Environmental factors and sleep preferences are important factors for consideration. Sleep is often overlooked and has significant implications for optimal health in persons with dementia. A comprehensive sleep assessment, finding underlying causes, and early treatment for sleep disturbances is important in the management of the neuropsychiatric syndromes of dementia. Thank you for watching, and we hope you'll return to listen to more modules on neuropsychiatric syndromes in persons living with dementia.